So now we will discuss clinical auscultation in pediatric cardiology. Auscultation, your description and your focus should be on the heart sounds, namely S1 and S2. Look for any additional sounds, S3, S4 additional sounds like click, and then murmurs. Don't be distracted by the murmur right away. Do follow this order, and there is a meaning in that. This physiologic diagram is to tell you the relationship between the different heart sounds and other physiological events. For instance, you know that it is S1 which marks the beginning of systole and S2 marks the end of it. With S1, the LV pressure or the RV pressure is rising. Then after the isometric contraction, the aortic valve is opening on the left side. With the occurrence of A2, the aortic valve is closing. There is a rapid decrease in the pressure in either ventricle. And then there is a slow filling of that ventricle. It proceeds towards the next first sound and next upstroke of the LV or RV pressure trace. The heart sounds are caused by the closure of the atrioventricular valves or the semilunar valves. S1 and S1 by the AV valves and S2 by the semilunar valves. We don't believe that the sounds actually come from the coaptation of the valve leaflets. It is a sudden deceleration of blood flow following the valve closure that causes surrounding cardiac structures and tissues to vibrate. These vibrations would generate S1 and S2. The first sound is caused by vibrations caused by the closure of mitral and tricuspid valve. It times with the end of diastole. If you remember that previous diagram, if you correlate the ECG, the pressure trace, and the first sound, it is with the peak QRS complex that the first sound times. It certainly occurs before the carotid of stroke. It is a high-pitched sound, and therefore you hear it best with your diaphragm. And 80% of the intensity of the first sound is from the mitral compound, what may be called M1, and only 20% is from T1. And the M1, being M1, is best heard over the apex, while the T1 is heard over the tricuspid area. This interval is less than 20 milliseconds, therefore you appreciate the first sound as a single sound. But there are circumstances where the first sound can be louder or it can be smaller. The integrity of the valve apparatus, the position of the valve leaflets at end diastole, the rate of increase of the LV pressure, and the PR interval are the deciding factors of the first sound intensity. I like to draw the comparison with a door and the way that door would be closed. If the door is very degenerate, squeaky, however you close the door, it will produce a dull sound. So if the mitral valve is calcified or fibrosed, it is going to generate a dull first sound. That is how the integrity of the valve apparatus influences the sound. If your door is wide open when you're beginning to close it, what would happen? The sound will be very loud. So if the mitral valve leaflets are wide open at the end of diastole, then with the onset of systole, they have to move across a large distance in a short time, and therefore you will find that the sound is loud. The rate of rise in LV pressure is another determinant. I will call it to the strength of your arm. If you slam it shut with a strong arm, you're going to hear a loud sound. But if you're gently closing it, you will hear a dull sound. The door is the same. Similarly, with the valve remaining the same, if the pressure rise in the LV is low, as in a myocarditis or myocardial infarction, you will get a dull first sound. The PR interval decides where the ventricular contraction occurs in relation to the atrial contraction. The PR interval is long, you have a dull first sound. A loud S1 can occur due to mitral stenosis, tachycardia, short PR interval, increased flow across the mitral valve. A feeble S1 in viral myocarditis, acute myocardial infarction, acute mitral regurgitation, varying intensity in complete heart block. Split S1 you can get in a complete right bundle branch block or Epstein's anomaly, in a left ventricular pacing, or in an atrial septal defect. The second heart sound, the most important thing that you need to make out is the splitting. You listen carefully in the pulmonary area with the child breathing quietly, and then you can hear that the second sound widens to allow you to appreciate two components to it. Why does splitting occur? It occurs, it starts to occur from the later part of the first week after life, first week after birth. The increased respiratory venous return to the right heart prolongs the right ventricular ejection and delays the P2. That is why you're able to appreciate the split in inspiration. And this happens because the pulmonary vasculature has a low resistance, allowing a longer hangout interval. The hangout interval is the time taken for the P2 to occur after the PA-RV pressure has crossed over. To explain that, when the pulmonary artery pressure is lower than the RV pressure at the end of diastole, you will expect that the P2 should occur, but it doesn't happen. It occurs after a short interval. That interval is called the hangout interval. The normal A2 is best heard over the apex and the aortic area. If you want to look at it another way, what you hear as the second sound is the A2, unless you are auscultating in pulmonary area and you are appreciating the split in inspiration. So evaluating an S2 will mean appreciate the split, normal, and the split could be normal, wide, fixed, or paradoxical. The normal P2 is less than A2 in intensity. If it is similar to A2 or louder than A2 or it's palpable, that is abnormal. So the normal splitting is the split widening in inspiration because the pulmonary valve with a longer hangout interval is handling an increased venous return. It is better heard in supine position because there is a greater volume in the RV in supine position. When the person stands, the sudden decrease in venous return takes away the splitting and you hear a single second sound. But S2 can be widely split. You say that it is widely split, then you can hear it in both inspiration and expiration, even though the split is still wider in inspiration. This may be because either the P2 is delayed or the A2 is occurring early. A delayed P2 is a feature of a mechanical problem like a valve PS when the ejection is delayed, Epstein's anomaly when the dysfunctioning right ventricle takes a long time to eject, or an ASD when there is a larger volume to be ejected. It may be an electrical phenomenon as in right bundle branch block, in LV pre-excitation, LV pacing, or LV ectopic. A wide split due to early A2 occurs in mitral regurgitation because the smart ventricle with the optimum diastolic stretch completes ejection earlier. Same thing happens in a small VST. Fixed splitting is a feature of AST. The split is audible with the same interval in inspiration and expiration. And the mechanism is in AST, the inspiratory increase in right heart filling is offset by the proportionate decrease in left to right shunt across the AST. Vice versa in expiration, and hence the RV output is fixed. What it means is there is a left to right shunt in ASD. This left to right shunt is more in expiration. In inspiration, as the left to right shunt is occurring, there is also an increased venous return which is occurring. It discourages the shunt from the left atrium. In expiration, the venous return is reduced, but there is a greater pulmonary venous return that's happening. So as far as the right ventricle is concerned, the input is similar in both inspiration and expiration, and hence the output is also similar. Therefore, it is ejecting a same increased output in both inspiration and expiration, and hence the S2 is having a fixed split. You can have the interesting condition called paradoxical split when the split is wider in expiration. The causes could be electrical, like left bundle branch block, RV pacing, RV pre-excitation, or RV ectopic. All these later conditions are like a left bundle branch block because it's the RV which is stimulated first. It can be a mechanical problem like in severe aortic stenosis or LV dysfunction, especially with hypertension. We spoke of the intensity of P2. A loud P2 denotes pulmonary arterial hypertension ordinarily, but if the PA is dilated, like it often happens in some children as an idiopathic dilatation of the pulmonary artery, or an atrial septal defect with a normal PA pressures, still the second sound is loud. In children with a thin chest wall or a straight back syndrome, you have a loud P2. The other extreme, a feeble or absent P2, is seen in tetralogy fellow, in severe valvar PS, pulmonary atresia, or truncus arteriosus. If you're speaking of the intensity of A2, a loud A2 can be heard in hypertension, a dilated aorta, or when the aortic valve is unusually close to the chest wall in tetralogy fellow or in transposition. The A2 becomes feeble if the aortic valve is calcified, or if there is severe aortic regurgitation, or simply if there is hypotension. The second sound becomes single either because the A2 and P2 have joined, they are both there, but they are fused, or one of them is missing. The fused A2-P2 typically occurs in an Eisenmenger VSD, where the pulmonary vascular resistance has become similar to the systemic vascular resistance. So both the valves close with the same hangout interval, and they occur at the same time. So you have a fused A2 and P2. Absent P2 in pulmonary atresia or absent pulmonary valve. In transposition, the pulmonary artery is posterior, so you don't hear the P2. Absent A2 is a neonatal feature in aortic atresia, such children do not survive. A calcific aortic stenosis in the older patient can be the reason for that. There is only one sound in truncus arteriosus because there is only one valve. We spoke of the first and second heart sounds. Now we are speaking of the third heart sound. The third heart sound is a low frequency sound which is attributed to the shudder of the ventricular myocardium when it changes from rapid elongation to slow elongation in diastole. So the chordopapillary structures and the chest wall impact are also implicated in the genesis of the sound. Is that too much of physiology? What we want to explain is one, why the sound occurs. The sound occurs from the heart muscle. When the heart muscle is changing from the rapid filling phase to the slow filling phase. We need to explain what happens in the normal, say, 5-year-old child who has a physiological third sound, and why at the age of 25 or 30, you call it abnormal, denoting serious heart disease. One of the determinants is an intrinsic property of the ventricular myocardium. So there is a rapid rate of elongation in the ventricular myocardium of a child. This property is lost as a child is aging. That is why you have a physiological third sound. In the older child or adult, it is a high atrial mean pressure with a normal AV valve orifice which causes a third heart sound. If commonly from the left side, when the left atrial mean pressure is high, meaning when the left ventricular end diastolic pressure is high, the filling occurs at a higher pressure. And that causes the myocardium to shudder, transitioning from a rapid filling to a slow filling phase. And that is the reason for the third sound. Or there is a greater flow which is happening during diastole, as in mitral regurgitation, aortic regurgitation, ventricular septal defect, PDA. That increased flow in the case of AR, relative narrowing, all these can cause in that diastolic event, which would be interpreted as a third sound. We often need to ask ourselves, is the third sound physiological or pathological? Since a child can have a physiological third sound. So an older child or young adult cannot have a physiological third sound. Beyond young adulthood, I would modify that statement to say that a pathological third sound could occur at any age, while a physiological third sound occurs at best in an young adult, usually in a child. Beyond that, you don't see that. It's a myocardial property causing the physiological third sound. It's a high filling pressure causing the pathological third sound. Occurrence with a gallop is a feature of the pathological third sound. If there is an associated S4, it has to be pathological. A physiological third sound disappears with exercise, while a pathological third sound is augmented by exercise. Presence of a cardiomegaly supports a pathological third sound. A pathological third sound goes with a high LV-EDP, an elevated BNP, a low ejection fraction of the left ventricle, and in the chest X-ray, cardiomegaly and pulmonary venous hypertension, and left atrial enlargement in the ECG. Now moving to the fourth heart sound, it's a low intensity sound due to the shudder of the ventricular myocardium due to late diastolic filling from the atrial contraction. It's heard best with the bell. Deceleration of blood flow and chest wall impact are all implicated. It is always pathological. So S4 is related to atrial contraction, and if S4 is there, it means the atrium has to contract more strongly than normal. And why does the atrium have to contract more strongly? Because the LV or the RV is very stiff. And that happens on the left side with hypertension or aortic stenosis, and on the right side with pulmonary hypertension or pulmonary stenosis. It will sound like a split S1, but remember, an M1-T1 split is heard in the tricuspid area, whereas an S4-S1 is heard over the apex vein. When you hear two sounds and you have a difficulty in saying whether it is S4-S1 or S1 or two components of the first sound, remember the two components of the first sound, meaning you are hearing the tricuspid component also. So that will be heard in the tricuspid area. A left-sided fourth sound will be heard over the apex vein. The other question is it an S1 ejection click? An ejection click is a much sharper and louder sound, and over the apex beat, it is a constant click. We will explain that shortly, meaning it has no respiratory variation. A left-sided S4 is heard best in expiration, and right-sided S4 in inspiration. An opening snap of mitral stenosis is a high-pitched diastolic sound caused by the sudden opening of the mitral valve in mitral stenosis, because the maximum excursion of the doming anterior mitral leaflet is reached, and the abrupt cessation of opening is responsible for the opening snap. The interval between the A2 and the OS will shorten with the severity of mitral stenosis. The more severe the mitral stenosis, the shorter the A2 OS interval and the longer the murmur. It's best heard over the apex beat, the left lateral position, and heard with the diaphragm. We're speaking of additional sounds now. So the clicks are important additional sounds. We use the word ejection click when the ejection into or across a semilunar valve is characterized by a click. You call the click phasic when there is a respiratory variation for the click, and you call the click constant when respiration does not cause any variation to the click. The phasic ejection click is a feature of valvar pulmonary stenosis. Why does it happen? When the pulmonary valve is doming, when the doming pulmonary valve is opening, as the valve reaches the maximum excursion, you hear the sound. That is the phasic ejection click of valve RPS. This is the only right-sided event which is louder in expiration. You expect a right-sided event to be louder in inspiration, but a phasic ejection click of valve RPS is louder in expiration. This is because in inspiration, there is a greater volume in the right ventricle, and which is pushing the pulmonary valve to a near open position. So during opening, the pulmonary valve is moving across a much shorter distance in inspiration. In expiration, there is a wider range of excursion, and which causes a louder sound. The more severe the PS, the click fuses with the S1. It comes closer to the S1. And as it becomes very close, you can't appreciate it as a separate sound, but there's a trick to recognize that it is still a click. In the pulmonary area, normally you don't hear the first sound at all. Certainly not as a loud sound. So if the first sound, what appears as the first sound, is louder in the pulmonary area, think that the click is fused with it. And when you recognize that it is louder, that event is louder in expiration, then you can confidently say the S1 is now fused with the click. In severe pulmonary arterial hypertension, there's a vascular click, and that click is constant. So the constant ejection click ordinarily comes from the left side, and it denotes a doving bicuspid aortic valve. And the click is constant because the aortic diastolic pressure does not allow respiratory variations in the volume of the ventricle to influence the position of the valve. A pressure of 80 is a very strong influence on the position of the valve to stay where it is, unlike a pressure of 5 or 10 on the right side, where it's a gentle pressure and increasing volume can influence the position of the valve. So the constant click of the aortic click is constant. It's best heard over the apex beat in the aortic area, and we have discussed how do you distinguish from the S1, S4 and M1, T1 combinations. There are other sounds that may occur also in the course of auscultation, like the vascular click of a dilated aorta, very common in tautology, less commonly heard in hypertension. A dilated PA can generate a vascular click. You may hear multiple clicks or eddy sounds in a long PDA. Non-ejection click of mitral valve prolapse, pericardial rub, where it's a triphasic, superficial, leathery sound. Now we move to murmurs. A murmur, you have to assess for the timing, grade, pitch, character, respiratory variation, conduction. We will explain each one of this. First, timing systole versus diastole. A systolic murmur is further classified as a pan-systolic murmur when it extends from S1 to S2, example a VSD or mitral regurgitation. An early systolic murmur that begins with S1 but ends before the S2, a small muscular VSD. In a small muscular VSD, what happens is in the later part of systole, the muscle contracts and obscures the VSD. In a large VSD also, you can get an early systolic murmur because the flow is only in the early part of systole. In an acute mitral regurgitation, you get an early systolic murmur because the rising LV-EDP closes the mitral valve prematurely. You use the word ejection systolic murmur when there is an interval after S1, and there is an interval for the beginning of the murmur, and there is an interval after the murmur before the second sound occurs. In other words, it's a mid-systolic murmur. The interval between S1 and the occurrence of the murmur is the isometric contraction. A late systolic murmur begins late in systole and ends with second sound, example, mitral valve prolapse or mitral regurgitation. A diastolic murmur can be early diastolic, an aortic regurgitation murmur. It begins with A2. Or a hypertensive pulmonary regurgitation murmur, pulmonary hypertension with the Graham-Steele murmur. They're both early diastolic murmurs beginning either with A2 or P2. You speak of a delayed diastolic murmur If pulmonary regurgitation is occurring because the pulmonary valve is not there or the pulmonary valve is not properly coapting, as happens after tetralogy repair, then PA pressure is not high. PA pressure is normal or low. In such a case, the murmur does not begin with P2. It happens an interval later. So you call it a delayed diastolic murmur. And it's very difficult to distinguish it from a mid-diastolic murmur, which occurs across the mitral valve due to an increased flow in mitral regurgitation or a VSD or a PDA. And on the right side, in an ASD, the increased flow across the tricuspid valve could cause a mid-diastolic murmur. A pre-systolic murmur can occur in mitral stenosis. It can also occur in Austin-Flynn murmur. An Austin-Flynn murmur is a pre-systolic and or a mid-diastolic murmur that occurs with a normal mitral valve in severe aortic regurgitation. In severe aortic regurgitation, the dual filling of the left ventricle and the fluttering of the anterior mitral leaflet in the incoming flow causes the murmur to be heard. That is the Austin-Flynn murmur. You use the term continuous murmur when the murmur begins in systole and runs across the A2 as in a PDA. We like to say how loud a murmur is. So Levine and Harvey graded systolic murmurs from grade 1 to 6. Currently, American Heart Association has graded diastolic murmurs from 1 to 4. The grading 1 to 6 of systolic murmurs, 1 is heard on intense auscultation, grade 2 is more readily audible, grade 3 is moderately loud, still no thrill, grade 4 loud with thrill. So grade 1 to 4 depending on the intensity, and grade 5 it's a very prominent thrill, and grade 6 even if you remove your stethoscope and keep it close to the skin, you can hear the murmur. You have described the pitch and character of the murmur. The low pitch is a feature of mitral stenosis. A medium pitch murmur is usually innocent murmurs. High pitch murmurs as in aortic regurgitation or mitral regurgitation. When there is a character to the murmur, you describe it, the blowing murmur of aortic regurgitation, a musical murmur of caudal rupture or aortic valvar avulsion, a machinery murmur of ductus arteriosus, or a honking murmur of mitral valve collapse. This illustrates some of the phonocardiographic depictions. Here's the first sound, here is the second sound. Look at the ejection systolic sound occurring after an interval, peaking in mid-systole and then decreasing. While in mitral regurgitation, look at a pan-systolic murmur extending from S1 to S2 and various other causes. Right-sided murmurs would increase with inspiration and left-sided murmurs will increase with expiration. So the site of maximal intensity of the murmur, you know that if the murmur is heard in the aortic area, it's either an aortic stenosis or an aortic flow murmur. In the pulmonary area, it is pulmonary stenosis, PDA, pulmonary regurgitation. Tricuspid area, a VSD murmur or a tricuspid regurgitation murmur. Over the apex, mitral regurgitation or aortic stenosis. In the back, coarctation, peripheral pulmonary artery stenosis, pulmonary AV fistula. And we try to look for a conduction. Conduction is the selective propagation of a murmur with same or greater intensity. Example, aortic stenosis to carotids, mitral regurgitation to axilla and back. We often come across innocent murmurs, particularly in children, where there is a vibratory murmur, a high-pitched murmur at the left sternal border. It's called the Still's murmur. The venous hum from jugulars and the brachiocephalic veins. Pulmonary systolic murmur, thin chest wall and straight back. Peripheral pulmonic murmur for pulmonary branches. When you are hearing murmurs over extracardiac location, you use the word bruit. There's no heart sound for timing. You speak of a carotid bruit when there is a carotid stenosis. You speak of an aortic bruit in coarctation. I'll just make a mention about dynamic auscultation. When you are altering the physiology and using that to your advantage to hear a murmur better, That's called a dynamic auscultation. A simple dynamic auscultation example is watching in inspiration, where the right-sided events are increased, like a tricuspid regurgitation, which becomes louder. Or altering the position of the patient, standing with a decreased venous return, when a smaller LV makes the mitral valve prolapse click and the systolic murmur to occur early, and a Hockham murmur also occurs longer. Squatting increases afterload, increases the venous return, and the larger LV delays the click and the murmur of MVP and the murmur of Hockham. And the Valsalva maneuver, during strain, the LV volume is smaller, hence MVP click and the murmur occurs early, and the Hockham murmur is also longer. This only to introduce you to the theme of dynamic auscultation. That's all. Thank you very much.